We are thrilled to have another RLR episode today where Reza and I share the lukewarm seat and enjoy discussing a case from the crowd. So if you do have a case, please volunteer to present it. I will, in the meantime, we'll have you get to know, if you don't know them already, the people who make VMR happen, without which all of this would be impossible. So, Kiara, do you want to say hi while we wait for somebody to bring up the case?
Hey, please bring up the case. I'm kidding. I'm Kiara and I'm cold today. I live in Lima, Peru, which is supposed to be a cool, no, it's supposed to be like a tropical country, but I am always cold. And yeah, maybe Vale can talk about it a little bit.
Hello, everyone. Good morning. Please jump in with a case. It would be great. And yeah, Lima is quite chilly. So we live by the sea, so it's common to have a lot of humidity. But hope we have a great discussion today. So I don't know, maybe Gabby can introduce herself.
Hey, hi, everyone. So I'm Gabby. I'm from Brazil. And I'm also very excited for today's case. So if you have a case, please, you can comment on the chat and we can listen from you. Kirtan, do you want to go and present yourself?
Yes, hello everyone. Myself Kirtan. I am from India and I am so excited for today's case. Rabi and Reza always have, fantastic chemistry. And I just wanted to add one thing, that I can't even imagine what kind of pleasure Rabi must be deriving when he solves case at, weird places. So I love this thing. And when you are in car and suppose he solves a case today, he will always remember it. I mean, how nostalgic and memorable it may be that I solved one case with lots of people in my car. So excited for that.
Thank you, Kirtan. I am in my car because I just went running with this lovely little creature, and we were supposed to have much more time to make it back home, but he was very slow and very hot because it's also hot here in California, and so we're stuck in our car, not stuck, enjoying the company of these incredible people. Ravi, do you want to announce the news, please? I just heard about it from my dear friend Charmaine, who actually is here. Oh, but she has her video off, so may not be in a space to share.
Hey, yeah, I was just jumping on that bandwagon. We've had a busy transfer market. Messi went to PSG, so Robbie's been upset because he's left Barcelona. But Ronaldo, actually, there was news that he was going to our rivals in Manchester City. But fortunately, this morning there was a U-turn, and Ronaldo's come back home. If anybody knows about Ronaldo, who's originally from Portugal. He was discovered at Sporting Lisbon in Portugal, and then was brought over to Manchester United as a teenager, and then developed there and won the Ballon d'Or. So now he went on to Real Madrid and then Juventus, and then has come back to Manchester United. So
coming back home.
Yeah, coming back home. So he's a little older, but hopefully we can get a few goals and maybe win the Champions League this year.
100%. 100%. It's a dream come true. I couldn't believe it when Charmaine texted me, and I'm still a little stunned, but delighted for sure. All right, y'all. I'm gonna mute myself for 30 seconds to a minute. Ooh, oh wow, another Friday special. Tiago, I'm really feeling a Tiago case today. It stretches me to my limits, and we'll need Reza's help. We'll be here shortly, so please unmute yourself. Tell us more about you, and then we'll love to nerd out with you.
So hi, everyone. My name is Thiago. I'm a physician in Brazil. Happy to be here. I'm always here as often as possible. And I don't have a case prepared, but I was just seeing my notes for this week, and maybe I can try presenting one here if there is no case.
Yeah, I think you should go for it, my friend.
Okay, so
I'm ready whenever
let's start with a 50-year-old male presenting with weight loss from 72 kilograms to 64, and that's it.
That's a great place to stop. I think in the United States especially, the obesity epidemic has us in a interesting space about how to approach weight loss. And of course, weight loss may be something that you want to celebrate with your patient and congratulate them on as part of their goal to get healthier. But as you all know, it may also be something to worry about tremendously because it may be a non-specific but very morbid marker of a disease. So if you're being simple about it, how do I know that weight loss represents something sinister or actually represents something to celebrate? And your first instinct may be to go on the guidance of your patient. Your patient may say, hey, I've been intending to lose this weight and so I'm happy. And that's a good marker, but it's not perfect. And it's not perfect because we all are designed in many ways to protect ourselves from any bad news. And we all have this protective mechanism, and it's very easy to see how someone can convince themselves that they're trying to intend to lose weight when the truth is that there's something else doing the work for them. And that thing that's doing the work for them is not something they want. So, of course, there's a whole list of things that can cause alarm. But the truth is, your instinct is better than anything. If you're inclined to give your patient a high five when they tell you the story of how they've lost weight, you probably should give them a high five or a COVID elbow and celebrate their weight loss. But if there's anything that causes you concern and instead of giving them a high five, you're sitting there thinking, what is going on? It's probably pathologic weight loss. And that's all I'll say. We'll see. I'll ask you all to apply this test with more HPI that Tiago gives us. And the question will be, are you inclined to high five the patient? Or are you inclined to wonder, hey, what's going on? So let's see what the next set of data does for that test. All right, Tiago, back to you.
So great. This weight loss, it was in 2 months. So it's the time. And for past medical history, no. Meds, no. Family history, mother with type 2 diabetes. Social history, nothing relevant. No health-related behaviors relevant, no allergies, but he was not feeling good. I was saying, I'm losing weight. I don't feel good. I have something. I don't know what's going on. So no history of diarrhea, no rashes, no night sweats. Yeah. So he denied everything. No lymph nodes that he could feel. Nothing different. No masses that he could feel. Nothing different except the weight loss. And he liked to walk about 6 kilometers per day. And he could walk this 6 kilometers per day and he was not feeling anything different. No abdominal pain, no nausea, no vomiting, nothing.
Oh, Tiago, very intriguing, very, very intriguing. I would love, Ravi, since we've heard your voice already, and now that I know I can ask for your input, I would love for you to share your 9Ds. I think people who are listening to this and may not see the chat would find it very helpful.
Yeah, I was just sort of, frameworks are often explored here, and I was like, had this quick sort of a slide or mnemonics. I love Reza's mnemonics. So one easy sort of mnemonic to remember are the 9Ds of weight loss. So many of them may not have particular relevance to this case, but we can explore them. One is depression, or then disease, which could be acute, chronic, could be all sorts of inflammatory diseases, dysphagia, dysgeusia, diarrhea, drugs, dentition, dysfunction, disability, and dementia. And exploring the inflammatory causes, actually, Rabi is a great schema for exploring weight loss. And one of the big, areas or buckets is inflammation or inflammatory disease.
I love that. And it's so helpful. Maybe as a group, when we come up with a simple answer, I'd love for a few folks just to put their answer in the chat. Are you inclined to high five this patient or are you worried? I know that seems silly, but maybe we can outline why we're worried. Amazing. Hey, Ramla, are you in a place where you can unmute yourself? Just tell us in the chat or go ahead and unmute yourself.
Oh, hi. Can you hear me?
Yes. Do you mind reintroducing yourself to the VMR crew?
Yeah, sure. So I'm Ramla Kisozi. I just actually completed my family medicine residency in June. So I'll be an attending real soon. Right now, I'm just enjoying this time off.
Wonderful.
And yeah.
How does that feel, by the way, the word attending?
Ooh, like excited, but like scary
Yeah.
at the same time because you're just like, ooh, okay, I have to co-sign all that stuff.
No, right? Hey, you've spent so much time and you've earned it. It's years and years of your life dedicated to it. So congrats and
Thank
and
you. Yeah, I'm very thankful for that. So it's good to, I almost forgot how it was to relax and have a summer. So this is my
know,
first
right?
in a while. So it's good.
Hey,
Yeah.
good.
All
So tell
right.
us why you're worried.
Yeah, I think, for me, when I approach weight, and this is like the family medicine side of me, about the weight loss actually, especially if I saw this person in clinic, and it looks like he's lost about, it was at 72 to 64 kilos. Yeah, so that's a lot of weight in a short amount of time. And considering his age, of course, when a patient loses weight, you have to know if it's intentional or unintentional. So if he's worried, he's losing it unintentionally, then I start thinking, is something happening like depression, or is he, I worry about cancers, and me thinking about, preventative screening. I start thinking, did you have your colonoscopy? Did you, just rule out those other major diseases? So that's sort of why I would be worried if this patient was in my clinic, just to ask him more questions about the weight loss, what has been happening.
I absolutely love that. I really, really do. And I think that it's so helpful to, as an attending, especially clarify and speak clearly with your learners why it is you're worried. And I think you'll notice that. You'll notice that around us in medicine, we're very good at saying the answer, but less good at explaining why. And that's why clinical reasoning remains to be a big space for us to grow. And I commend you for being so crystal clear on the why here and what you would do. So I'm gonna outline the lay of the land here. And share the approach to weight loss that Ravi was mentioned that we have on the website. But I'm going to prime you with one thing that I'm really mulling about, which is that we have two opposing things here. We have that this person has lost over 20 pounds, around 20 pounds, and we have to merge that with the fact that his exercise tolerance remains unchanged. He's still, despite losing 20 pounds, able to walk 6 kilometers a day. That's no small amount. So as we share this approach of weight loss with you, I want you to answer the question. Well, one, if this is new to you, take it down, think about it, process it, but also ask yourself, how can you marry this with the fact that his exertional capacity appears to be unchanged? But two quick things before you enter the world of weight loss. Is it verified? Scales are different, and you want to make sure you're not going down the wrong schema. And two, this is what we talked about. This is the high five sign. If it's not pathologic weight loss, you don't need to solve. There's no problem to solve. But if the weight loss is true and you're not inclined to high five the patient, start to think. And the real tension is, are we going to go IMAID, infection, malignancy, autoimmune drugs, or are we going to go non-inflammatory causes of weight loss? And the non-inflammatory causes of weight loss are simply a numbers game here, intake and non-absorption, where you're not eating enough calories, no matter how much you exert yourself, because you have no access to food, you don't have the desire to eat, or there's more discomfort while you eat. Even if the process to bring the food into your lumen is perfect, you may not absorb it very well. There are some diseases that at the end stage of any organ dysfunction, lung, heart, liver, kidney, you start to lose muscle mass. The endocrine diseases are tricky because they have inflammatory phenotypes to them. Weight loss from extreme insulin deficiency or resistance doesn't have much inflammation, but hyperthyroidism and adrenal insufficiency can have phenotypes of inflammation. So this is a plus minus here. And then of course some meds. Meds don't usually cause profound weight loss, but can certainly contribute. So take this in, please drop in any questions you have in the chat, but I would love for you to let's go to the place of tension here. What would cause 20 pounds of weight loss and yet leave a patient able to walk 6 kilometers? So I'm going to pause for 30 seconds to a minute and look for the wisdom from the chat. Daniela, go ahead. Share us your thought. I agree with it, by the way. But how did you get there?
Oh, hi everyone. So to introduce myself, my name is Daniela. I'm a medical student from Brazil. I'm in my 4th year out of 6. I actually had a class yesterday on hypothyroidism, so just hoping for the best now. So usually hypothyroidism will present with basically the opposite of hypothyroidism, which is the one that we think about more, at least in my opinion. Tiago probably has a different opinion than mine on that one. But the patient will have a high rate of metabolism. And that means that he will burn through calories a lot faster. He is going to have a lot of weight loss and basically all the symptoms that can come from having a super active metabolism. And I think that kind of fits with what this patient is feeling. So he still has a lot of energy and he's able to go about his day. He's just not feeling good, but any other symptoms are not present. And what I think would be interesting in this case would be to check how the thyroid is doing, and just having an idea if it is functioning well or if it's super active.
I think that's superb. And I'm going to zoom out and then zoom back into what you said, because I think there's a lot of truth in it. And it is probably a great example of what we'll talk about. It's really important in medicine to understand that things happen in proportion to each other. If I bump into this steering wheel in the car in front of me and I break my rib, there's something else going on. The trauma is not proportional to the consequence. It must mean that I have an underlying bone problem that caused my bone to break despite very minimal trauma. When somebody is losing 20 pounds or 8 kilograms of weight because of an inflammatory cause of weight loss, that must mean that the inflammation is severe and aggressive. To lose 20 pounds means there is out of control inflammation. There are some diseases that are inflammatory over a long period of time that sneak up on you as weight loss, but most diseases, like think about metastatic cancer, tuberculosis, raging vasculitis, the amount of weight loss is going to be proportional to disease severity, such that, here's the key sentence, there will be anemia of chronic inflammation as the easiest cause of a reduction in exercise tolerance. There are many ways that patients with inflammation have a reduction in exercise tolerance. They get muscle wasting, they get cardiovascular dysfunction, they get pulmonary dysfunction. But anemia of chronic disease is virtually ever present in an inflammatory cause of this degree of weight loss. If you're telling me somebody's inflammation has lost 20 pounds, I'll tell you their hemoglobin has to be less than 11. So I think that the preservation of exercise tolerance tells you that anemia of chronic inflammation or any anemia is unlikely to be present, and therefore prioritizes the things on the left side of the screen that we saw. And so endocrinopathy is a great example. Chronic organ, I'll just pull it back up again, actually. So if we're saying inflammation is present and 20 pounds of weight loss is there, anemia of chronic inflammation, cardiovascular dysfunction, muscle wasting, lung dysfunction is not going to let this person walk 6 kilometers a day. Impossible. Not impossible. You never want to say impossible, but it's very unlikely. So we're probably here. These things are not going to creep up on somebody walking 6 kilometers. Impossible. Cross this off. This is not going to cause 20 pounds of weight loss. And these things have GI symptoms, you know? And of course, we're all biased by knowing that we have a master endocrinologist playing with us. But I think you can make a logical argument that this is not happening, that this is not happening, that this doesn't cause this degree of weight loss in isolation. So let's study intake, malabsorption, and endocrinopathy. And you gave us a great example of an endocrinopathy like hyperthyroidism. Now, I don't know this. This is clinical reasoning. This is making inferences and judgments by different pieces of knowledge in different parts. No one has studied this probably. So I'm curious what you all think. I'm going to scan the chat for any counterpoints or additional reflections. But I think we have Prof. Rez here. If it's true, do you want to say hi real quick?
Hi, everyone. Sorry for showing up late. I was rounding, but so excited to be here. Robbie, are you driving?
No, I'm just hanging out in my car.
Okay, good.
Yeah, don't worry. How was your morning?
Morning's amazing. I have
Yeah.
a terrific team, very eager medical students who are just growing at a faster rate than my mutual funds are. And my mutual funds are growing pretty fast.
Woo! Amazing. Well, folks, Daniela, since you were just thinking about the case, do you feel okay summarizing what we've learned so far? If not, I'm happy to do it, but I wanted to give you the platform first.
Oh yeah, of course. So Thiago is presenting the case, and we have a patient with chief complaint of weight loss. He's a 50-year-old male who came to the appointment complaining of 8-kilogram weight loss over the last 2 months, and his main complaint is he's not feeling good, and he denies any other symptoms. So diarrhea, rashes, night sweats, lymph nodes, none of that are altered, all normal, and he's still, even with that the weight loss, able to walk 6 kilometers per day, and basically on his past medical history, there is nothing happening, none. And family history, he has a mother with type 2 diabetes. And that's where we're at. We're thinking about hypothyroidism, by the way.
Incredible. Thank you so much, Daniela. All right, Tiago, back to you, and I'll have listen to the magic reflect on your next aliquot.
Great. It's amazing to see you thinking about the case and all this crowd. And just to make it clear, it's in the outpatient setting, and his heart rate was 72. His height is 1.84 meters, and his BMI was 18.9 at the time he came to the clinic for the first time. And for his physical exam, everything was normal. I could not feel any masses in his thyroid or whatever, and no murmurs in his heart except what is expected to be there, and nothing different. Everything's normal. And I'll pass it on to you.
All right. Hi, Tiago. This is very interesting because we have a middle-aged individual, no past medical history, I would say here with non-inflammatory weight loss. And we have to keep it at non-inflammatory for now because nothing about the HPI is suggesting pathology of a specific organ like the lung, pneumonia, GI tract gastroenteritis, liver, hepatitis, urinary tract infection with dysuria. So nothing is suggesting infection. Additionally, on exam, there's no murmur to suggest subacute endocarditis. So at this point in the case, it's framed as non-inflammatory weight loss. And this is where Tiago finds himself. But folks, there's other markers of inflammation that we should send for. This includes the white blood cell count, the albumin, the platelet, the ferritin, the ESR, the CRP, and I would send these just to make sure that we're dealing with non-inflammatory weight loss, because that's a game changer. It's a game changer. And what's the threshold to actually pan scan looking for an occult malignancy? I'm not there yet. So when we're approaching this as non-inflammatory weight loss, all you have to do is think about eating food. What happens when you look at Robbie right now? He took a swig of his AHA. Is it AHA? Yeah, I got one diagnosis right today. He took a swig of his AHA, and what happened? So he had to have the motor coordination, the muscle strength to take this can to his mouth. He has to be able to swallow. So swallowing has to be intact. Once he actually swallows, then he has to be able to absorb the nutrients from the GI tract. So you can think about any lesion in any of these steps can lead to weight loss. Because ultimately, weight loss is a simple formula. It has to do with calories in and calories out. Calories in and calories out, there has to be an imbalance for there to be weight loss. Calories in, meaning calories you use and calories that you consume. Those are the factors that you got to consider here. So I have one question for Tiago before I share some additional thoughts. Tiago, has his appetite changed? Is he eating less than usual or not? This is going to be very important, folks.
So he was not eating less than usual. He said his appetite was preserved and not increased or decreased.
Okay, so now we find ourselves in a fascinating space. And here I'm going to take the ball, pass the ball. So I want to set this formula up for you again. We've all tried to either lose weight or gain weight, but probably the majority of us have tried to lose weight. When you want to lose weight, there's two things you can do. You can eat less, or you can increase your activity, increase your metabolism. Those are the only two things. Either you're burning calories or you're taking in less calories, right? We know he's not burning more calories. We know he's not taking in less calories, and we know he's not inflamed as of yet. So Robbie, where are you now with the differential diagnosis with this frame?
I'm right there with you. I think that the inflammatory causes of weight loss are so much more morbid that even though the signal is moving away from them, we have to study the landscape in more detail to make sure we're not missing anything. But the spotlight is certainly on the non-inflammatory causes. And it's not too surprising, I would say, to layer on that the non-inflammatory causes leave subtle or no evidence on exam. It's hard to have someone lose 20 pounds from a chronic infection or a chronic malignancy or an autoimmune disease and not have a signature on exam. So I think probability, non-inflammatory, morbidity, inflammatory. So we have to do both for now. All right, Tiago, back to you.
Okay, so for his lab, I'm just seeing right now here in his notes. So creatinine 0.75. So cholesterol 170, 8GL 80, triglycerides 100, hemoglobin 14.6, leukocytes 6,530, platelets 232,000, TSH 0.97, free T4 1.2, ESR 10, PSA 1.5, toxo negative, EBV negative, CMV negative, HIV negative, VDRL negative, ferritin 200, fasting AST 23, ALT 20, and I think that's it. And fasting glucose 330, A1C 9.9.
Ooh, intriguing. I'm sorry, I might have missed it, Tiago. Did you happen to give us the sodium, potassium, and all that, or are you saving that for later?
So let me find it here. I have it. So potassium 4.2, sodium 140.
And do you have the diff on the white blood cell count or
I don't have, I didn't take the differential on my notes.
at all?
Sorry.
No worries at all. So I think maybe I'll reflect on the CBC, which is normal, and I would say that that's very helpful, and pass on the harder part, the electrolytes, to Reza. And I'll tell you that I think we're pretty confident now that you're not dealing with an inflammatory cause of weight loss. And it's not so much that the white count is normal, because you can have immunocompromising conditions like advanced HIV result in a devastating consequence of HIV, but a normal white count. It's not because the platelet count is normal, although thrombocytosis can be a marker of chronic inflammation. A normal platelet count isn't super against a chronic inflammatory disease. What really strongly argues against an inflammatory component is the normal hemoglobin. It takes very little inflammation for the hemoglobin to go down. It's just like the albumin. It's very hard to make a cause for an inflammatory disease for 2 months with a normal hemoglobin. So I think now the spotlight is on that non-inflammatory aspect of the weight loss schema. And the question is which one or which ones? And maybe the electrolytes will give us progress, maybe not. I'll pass Reza to inspire us and teach us.
Thank you so much. This is a fascinating case, folks. And I agree 100% that this is non-inflammatory weight loss. And it's not because of depression. It's not because he doesn't have access to food. It's not because he's decreased his oral intake. I think going back to our formula of calories in and calories out, so we know it's not decreased calories in, and there's no diarrhea to suggest malabsorption, though it's always on the DDX. So we have to think about something that is either causing him to lose calories through the urine or causing increased caloric metabolism. So we're in this world of endocrinopathy here, not just because Tiago is presenting. Even if Tiago wasn't presenting, we would be in this world of endocrinopathy. So now we have to review the various endocrine disorders that can result in weight loss. And that would be my first pass in evaluating this patient's weight loss. Of course, you would want to make sure that there's age-appropriate cancer screening, because that's a do not miss. For example, like a colonic malignancy that can have a very subtle presentation. So we must consider that. But if you go through the endocrinopathies, could this be thyrotoxicosis? Well, let's look at the other clues for thyrotoxicosis. These patients can have hyperdefecation. They can have tachycardia, heat intolerance, diaphoresis, and various physical exam findings. We have no other clue for thyrotoxicosis. And more important than everything I said is something I forgot to say. His TSH and free T4. This is not thyrotoxicosis. I forgot Tiago gave us that. All right. I'm going to leave the diabetes discussion for me and Robbie to go back and forth, because certainly you can have diabetes, hyperglycemia that leads to polyuria and weight loss because you're not absorbing the calories. You might say, wait a minute, Reza, he's older and he's not overweight. How could he have diabetes? Well, there's various forms of diabetes. So we'll talk about that together, me and Robbie. The other endocrinopathy to consider is adrenal insufficiency. And this is why Robbie asked about the diff on the white blood cell count, because these patients can have a mild eosinophilia. And this is also why he asked about the sodium and potassium. The thing with the sodium and potassium, it's not always there. Patients don't read the textbook. So many patients can have primary adrenal insufficiency without electrolyte derangements. There is no physical exam clue. There's no CBC clue, and there's no electrolyte clue for adrenal insufficiency, but it's something I would send in this patient as an AM cortisol because it's on the DDX. Pheochromocytoma can also result in weight loss despite normal food intake because it's a hypermetabolic state with the catecholamine surge. You may say, well, where's the tachycardia, the hypertension? Yeah, it makes it less likely. It doesn't rule it out, but it makes it far less likely. So I would put AI over Theo. But then, Robbie, let's talk about diabetes, my friend, because this patient didn't have a history of diabetes. He has a fasting glucose of 330, an A1C of 9.9, so he's hyperglycemic. Can all this explain his weight loss?
Oh, every time Reza talks, I'm a little bit like just entranced and mesmerized, and I just realized why. Did you hear how he asked that question? He like set me up, and he's like, "Pause. Can this be the cause of weight loss?" Full stop. This is unbelievable. Thank you for that alley-oop. Yes, I think it definitely can be the cause of his weight loss, but it may be counterintuitive, and I can't wait to learn from Tiago because this is a space that I feel like I'm learning. But here's my best shot. Most diabetes in a 50-year-old man occurs because of insulin resistance. Insulin is not working well. That, in its simplest form, is called type 2 diabetes. And what is happening is insulin is there, but the action on the cells is absent. What is the reason that there is insulin resistance? There are many reasons, but the driver is a combination of genetic factors, look at his family history, and weight, hence the term metabolic syndrome. So everyone who is developing diabetes has less of the anabolic effects of insulin, should have less weight gain, and actually everyone with the evolution of diabetes, technically because of less action of insulin, should lose weight. But it's such a complex interaction because in patients with the most common type of diabetes, type 2, have the weight driving the insulin resistance, which drives a little bit of weight loss, so they tend to be overweight. It's very counterintuitive, but if you just take the following fact, if insulin's not working in anybody, they will lose weight. But if the reason it's not working is weight gain, you end up with a net weight gain. How do you know this? In patients with type 2 diabetes where the insulin resistance is driven by weight, if you give them insulin as part of their treatment, they'll gain even more weight. So here we have a patient with a BMI of 18, right? It was 18. A BMI of 18, an A1C of 10, and who's losing a lot of weight. You have to wonder, do they have an unusual cause of diabetes as an adult because of how much weight they're losing, how low their baseline weight is? And I'll pass the mic to Reza to see his reflections, but I'll share this with you in a moment. There are some fancy causes of increased insulin resistance. I'd make the argument that he doesn't have this, or he might, base rate would tell you he has this. He has just regular old insulin resistance from a combination of family history and being overweight. 90% chance. But there are a lot of things that argue against that. His BMI is low, and we'll see how much insulin it takes to control him. But his BMI is low and he's losing a lot of weight. So the question in my mind is, does he have a fancy cause of secondary insulin resistance? None of the meds are at play. Does he have an endocrinopathy? Does he have a genetic predisposition to insulin resistance? Does he have these infections that contribute to insulin resistance? Or does he have something else? I think that because of his low BMI, you have to worry about insulin deficiency here. And the most common cause of insulin deficiency is autoimmune in nature and is essentially type 1 diabetes, which is 10% of diabetes in older adults. So that's where I'm at. I actually don't, I think in real life, I'd be calling endocrinology and getting their input, but there's enough atypical features, his baseline weight, how much weight he's losing, for us to move away from 90% chance that he has type 2 diabetes and start to wonder, does he have a fancy schmancy secondary cause of insulin resistance, which is unlikely based on his weight, and move towards this area of the screen. And this area is usually populated by a type 1 or autoimmune autoimmune pancreatic disease. Where are you at with this, Rez? What do you think?
I I really can't add anything to that. And it would be an insult to the audience if I continue speaking and not pass the mic to Tiago, because at this point, he's the only person I want to listen to.
Yeah, I can just add the values, what I did and what came back, because this discussion is are you endocrinologist? So that's the question I have. So I don't know, you don't need to call endocrinologist, Rob. It doesn't make sense. Anti-GADI 1,728, and the normal range is less than 5. And anti-IA2, the islet antibody, it was 100. And the reference range is, I don't know, I think it's 7.5, but it's very high. So both are very high. And I think that's it. So the first visit he had was in June of 2017, and I saw him again this week. So for this reason, I could remember of him to present this case, as there was no case, and now his weight is 78.4, and his A1C, let me find it here now, is 6.7, and he's taking glulizine and glargine. So glargine 13 once per day, and he's counting carbohydrates, one for each 18 grams of carbohydrate, I don't know how to say this word, in each meal he takes. And I think that's it.
That was phenomenal, Tiago, because this is bread and butter medicine, isn't it? Bread and butter medicine, and so relevant and so educational. And I think the one point to make to the audience is that when you have a feasible cause of weight loss, here being the hyperglycemia, an appropriate step would be to treat the hyperglycemia, follow the weight. If the weight doesn't improve, then still consider other sinister causes. If the weight improves, then you're done. You don't need to waste resources further investigating this patient's weight loss. And now to the partner of Tiago. Are you guys in the same room right now, Tiago?
Yeah, but Reza, I just want to make just one comment. So when I saw what was going on, his glycemia, I was worried. So most cases are type 1 diabetes, and as Rab said, it's very important to have it in mind that we have many patients. So I can remember right now 4 patients that I have in my clinic that they have late onset type 1 diabetes. In the past, it was called LADA, latent autoimmune diabetes of the adult, but now it's just called type 1 diabetes. Most patients with type 1 diabetes, they develop it earlier in their lives, but they can develop late. And many patients, I don't know why, but I was just having this conversation with Gabi during our lunch that I see many patients coming in my practice being treated with metformin, and the A1C is 10. It's because they have type 1 diabetes, and no one realized it's type 1 diabetes because it started when they were in their 50s or 60s. It happens a lot. And when I saw this case, my preoccupation was, is it a pancreas cancer? I'm really worried about it, or is it autoimmune? Because these are the 2 most common causes for that column that Robbie showed us without further history. So everything's normal. It can be an early sign of pancreatic cancer. So actually I ordered him ACT. I should not thinking now, but I was worried about it, and his CT was normal. But with this positive autoantibodies, we can be confident that it's just a cause. And another remark that I want to make is about adrenal insufficiency, because it causes weight loss, and it is related to type 1 diabetes because the most common cause is autoimmune. But a great clue you can have is the hyponatremia. So it's very common to have patients with adrenal insufficiency and a normal potassium, but it's not common at all to have a patient with adrenal insufficiency and a normal sodium. So hyponatremia is present in more than 95% of cases with adrenal insufficiency. So when you see this guy who is losing weight and he has type 1 diabetes, you have to think that there is a possibility of adrenal insufficiency be here as well. But if the sodium is normal, then the suspicion is not so high. That's another remark I have. And thank you for this discussion. It's amazing.
Joe, this is one of my favorite cases, honestly, because I think we get so much repetition. And, you know, if you I'm really curious, and I hope we can do this one day, where we study the cases presented on VMR and plot out what is the base rate. And I think the base rate is probably tuberculosis #1, and some like other rare and esoteric infections. And the base rate of common diseases on VMR is so low that I really appreciate you walking us through this journey. And I actually want to ask you a question that I don't know what I would do in real life. When you have a patient like this and you don't know what the diagnosis is, and you'll get a diagnosis in maybe 1 week or 2 weeks, depending on CT scan, or what is your advice to us of who we should start insulin on before we know the answer? Like walk me through your first visit. You don't have the antibodies back. You don't have a CT scan. You don't have anything. How do you decide, oh, I should start insulin or I should start metformin before the answer is back?
Yeah, so it gives me opportunity to talk about other things, because there are 3 autoantibodies, and I don't know if you noticed, but I didn't ask insulin. I didn't ask why, because I introduced insulin, and you should not order insulin if someone uses insulin, because then it will be positive. So I started insulin. If you have a high A1C higher than 9, you should use subcutaneous drug, be it GLP-1 receptor agonist or insulin. And if you suspect it may be type 1 diabetes, then it needs to be insulin. So once I saw his glucose and A1C, I started him on insulin and ordered his exams. And I didn't order anti-insulin because I said, you start it right now. You take insulin now. Does it answer your question?
Yes, beautifully. Maybe since we have a minute, I'll ask you, what if his A1C was 7? Would you have started insulin, and how would you have used that? I'm really curious because I think in the ER, this comes up a little bit for me, you know?
Yes, it's amazing. Yes, I would. And if the fasting glucose is 330, you can be sure that if he has insulin, it's not working. So I would start insulin based on the glucose because, you know, it's been here for months, so the AC is high. But as you said, he could present with a DKA in the emergency room, and the A1C would be like normal. But if you have a suspicion for diabetes and glucose is over 300 and it's there, I would start insulin. So if you have doubt in diabetes, just give insulin and then you change it. No problem in changing it. So there are patients with type 2 diabetes. There is one patient I can remember. I was called in the hospital because his glucose was in the 700s and it was type 2 diabetes, and he was started on insulin. And nowadays he just takes metformin because after glycotoxicity wanes, then he's okay. So, but you know, if you have doubt, if you think about insulin, use insulin, and then you can change the medications in the future.
Epic, Pearl. If you think about insulin, just use insulin. I love how you're such a great teacher, but you keep it so simple at the end of the day. Thank you so much. All right, Gabby, I've hogged the mic enough. Please take it away, my friend.
Great. So I learned so much with this case. Let me find here my teaching points. So we discussed about weight loss, and we discussed a little bit about if we are going to investigate it or not. And usually we think about, is it an intentional weight loss or not? But Rabbi reminded us that sometimes the person may say it is intentional when it's not, so we have to be aware of that. And weight loss occurs as an imbalance between calories in and calories out. We have learned that if an imbalance occurs, then the person either will gain weight or lose weight. We learned about the 9 Ds for weight loss, which are depression, chronic or acute diseases, dysphagia, diarrhea, dysgeusia, drugs, dentition, dysfunction or disability, and dementia. There are inflammatory and non-inflammatory causes of weight loss, and inflammatory causes are usually more morbid and usually have associated findings, such as fever or increased lymph nodes in exam, and among others. Also, we learned that anemia or chronic disease can occur in inflammatory causes of weight loss, especially in greater degrees of weight loss. And this can present in the history with a decrease in exercise intolerance. A normal HB, which was in this case, is a clue for a non-inflammatory cause. We discussed also the endocrinopathies that cause weight loss, and we discussed thyrotoxicosis, adrenal insufficiency, pheochromocytoma, and diabetes. Regarding thyrotoxicosis, usually the person has tachycardia, heat intolerance, diaphoresis, and also altered TSH and T4. 3 to 4, I mean. Adrenal insufficiency will have eosinophilia, altered sodium, usually hyponatremia, which is present in most of the cases with adrenal insufficiency, and potassium, which is not always altered. Pheochromocytoma will have a hypermetabolic state, hypertension, tachycardia, and headaches. And diabetes, which was our fourth cause of endocrinopathy that causes weight loss. So diabetes is due to hyperglycemia that leads to polyuria that leads to weight loss. It can happen because the insulin is not working, usually type 2 diabetes that has insulin resistance or other forms, and insulin deficiency, which is usually type 1 diabetes. So this case was a late onset type 1 diabetes that previously was called LADA. And Thiago also taught us about 2 causes of weight loss with a normal physical exam that we usually have to roll out, which are pancreatic cancer and autoimmune disease. That's it. Thank you for the case and for the discussion.
Thank you for a superb summary of it. Really, really, Tiago and Gabby, the power couple of medical education. It's so nice to learn from you both. Yeah. All right, y'all. Have a wonderful day, and hope to see many of you tomorrow. Your beloved Rafa Medina will be facilitating Global Virtual Morning Report, so hope to see you there. Bye.